Hello friends, today now we'll discuss about ventilation and perfusion and their ratios. So ventilation and perfusion. Ventilation is, there are two types of ventilation in our lung, that is pulmonary ventilation and alveolar ventilation. Pulmonary ventilation means that is in and out of the air, that is normal tidal respiration into number of breath per minute. So usually we take 12 to 18. Let's consider that. Let's consider, we are saying about that pulmonary ventilation. Pulmonary ventilation is tidal volume into breaths per minute, that is suppose 12 is 500 into 12, 560, 6 liter. So pulmonary ventilation, this much amount of air that goes in and out from our lung. This is per minute, that is pulmonary ventilation. But among the 6 liter, whole doesn't take part in respiration. The amount of air that take part in respiration is called alveolar ventilation. So alveolar ventilation is equal to 500, that is tidal volume, minus 150, that is dead space, into respiratory rate per minute, that is 12. So it is 350 into 12 is equal to 4.2 liter, that is 4200 ml. So this is the amount of air that actually take part in respiration, take part in exchange of their gases, exchange of the material, exchange of oxygen, and taking the carbon dioxide from the blood. This is the amount of air that takes part in actual respiration. Now there is where this 150 came. It is the amount which is called dead space. The dead space is what? Dead space is actually the amount of air into our lungs that doesn't take part in the respiration. So we have a lungs, there is a conducting zone and respiratory zone. In conducting zone the air remains, but it doesn't take part with the in exchange of the oxygen or anything. It doesn't take part in the respiration. So the air that remain in the conducting zone are actually dead. Means not actually dead, but they are in the dead space. Means they are not taking part in the respiration. That it means. So it is about 150 ml. This is in normal. This is called dead space. Anatomical. There are anatomical dead space, physiological dead space, and pathological dead space. Anatomical dead space is this the conducting zone. There is air but doesn't take part in respiration. So these are anatomical dead space. Since some in healthy person like us, the anatomical and physiological dead space are almost equal. But in some case there might be more than this. Anatomical is fixed. You have same dead space, I have same dead space. But in some of the patient, or there will be a physiological dead space. Some of the individual we can say that in the apex normally there are the less blood supply, but when air comes, it remains in the apex. There is a less blood supply. Where there is a blood supply, there only the air can be exchanged. The air that is not away from the blood vessels, they are not taking part in the respiration. So they become physiological dead space. It is not as the pathology. It has nothing to do. It is normal phenomena that is in the effects of our lungs. There we find that some part of air doesn't take part in the respiration. So that is physiological dead space. What is pathological dead space? Pathological dead space means suppose any part of our lung is there, ventilation is coming, but the blood supply is not there, or the blood supply is there but it has been blocked due to some thrombus, embolism, anything like that. Suppose you have a pulmonary embolism, thrombosis is there or embolism is there. So what happened? There will be the distance from the place from where the thrombus is there, embolus is there. After that, there will be no blood supply. So you are taking air, oxygen is reaching there, but blood vessel doesn't have the blood. So oxygen is not taking part of place. There is no exchange, and that is pathological dead space. I hope you understand this also. Now our ventilation, which we are talking about, is the alveolar ventilation, that is 4200 ml and ml. Now when we talk about the perfusion is the blood supply to the lung, and it is around 5 liter. So in each minute we say that 5 liter of blood is supplied to the lung. Now What is ventilation perfusion ratio? In the apex, so I have described, and there can be divided into zone 1, zone 2 and zone 3. In the apex, what is there? There is more air but less blood supply. In the apex of the lungs, it is determined anatomically that there is less blood vessel to the apex, and in the base there are more blood supply. So when air comes in, it goes to the apex, there are less blood vessel, less blood supply. So now the all air doesn't take part into the gas exchange. So there are actually lot amount of air in the apex region that is not taking part in the ventilation, that taking part in the respiration, that is doesn't take part in the exchanging of the gases. So ventilation is there are more air, more oxygen, but blood supply is less, which is normally 3, that is 3 times more ventilation is there in comparison to the blood supply. This is normal. So at apex there is a wastage of the ventilation, there is a wastage of the air, and there is more content of oxygen at the apex. Because of that, you know about Mycobacterium tuberculosis, it is an aerobic organism. Aerobic organism means any organism that live in the presence of oxygen, that require oxygen to live, and the maximum oxygen present in our lungs is at the apex, because we have high ventilation over there, and it remains in there. Oxygen content is very high at the apex. So when anybody, if he is going to have a reactivation of the TB, then that Mycobacterium tuberculosis, which is an aerobic organism, will grow where there is more oxygen. More oxygen is in apex. So in apex they will multiply, they will get nutrition, oxygen, and they will multiply, and there is a reactivation of TB from the apex. So always remember, if the person has the TB, it is a primary TB, then it will progress anywhere in the body, anywhere in the lungs. But if it is a reactivation of TB, that you have exposed to the bacilli, that had been body has immunity, it has sealed off somewhere in the body, that has been in the dormant stage, the TB maximum case in our we all South Asia, in Africa part, they all are those endemic region of the tuberculosis, they are already have latent TB or have TB that has been suppressed by our immunity. But when our immunity goes away, when we have a certain disease, we use the immunosuppressant after transplant, or some like a rheumatic disease or immunomodulatory disease, we require the steroids or immunosuppressant, or patient gets HIV, anything that's lower the immunity. Now this becomes activated. Where from it will be activated? There where there is more oxygen content and it is in the apex. So reactivation TB is always from the apex. So what do you understand? At the apex zone 1, where there is the ventilation perfusion mismatch, that is normally ventilation is more, perfusion blood supply is less, and which is normally 3. So there is a wastage of ventilation as a normal. This is a normal phenomenon. When at the base, when it comes to the air, there is ventilation is actually more than this, but the blood supply is even more, meaning that we have a very high blood supply at the base. So there is the airs that come in, the ventilation that come in comparison to that, the blood vessel, the perfusion is more, the blood is more. So the ventilation perfusion ratio comes down to 0.6. This normally indicates that there is a wastage of the perfusion. The blood that goes, that 100% is not getting the amount of oxygen that it needs to get. So it is 0.6 ventilation perfusion ratio. Now when there is any obstruction, suppose any part of the region is obstructed, ventilation is 0. Suppose any bronchus, any lobe, any part, any bronchus is obstructed. Now beyond that, oxygen, air cannot go. So ventilation is 0. Now there, but blood supply is coming. Blood has come. It doesn't receive oxygen. It doesn't receive any air. It doesn't see any oxygen or air there. So there is obstruction. Ventilation is 0. Because of that, now ventilation perfusion ratio is equal to 0, and in 0 by anything is 0. So what happened in that case? If you give the oxygen supply more to the patient, it is not going to have. Why? Because you are giving oxygen, but it is not reaching there. That is the obstruction. Ventilation is not going there. So there is no point of giving oxygen, or even you are giving oxygen, it is not going to have. You have to remove the foreign body or obstruction. That is the utility of ventilation perfusion becomes 0, then it will not help. That is the indicates. But if there is ventilation is coming, there is no obstruction, but now blood is not going due to any obstruction of the blood. Suppose say pulmonary embolism. So there is an embolus. Now blood is not going beyond that. There is no blood in the lung, but air is coming. So and ventilation is there, but lung blood supply is not there. So blood supply is zero. Anything by zero, under zero it becomes infinity. In this case, normally we think that even though there is this obstruction, the pulmonary embolism is there, but it doesn't leads to 100% obstruction, or there may be a collateral blood supply. That means there must be some blood is going there, and because of that, if you are increasing the oxygen supply, then it will increase the PO. That is about ventilation perfusion ratio. I hope you have understood. Thank you.